and good afternoon, ladies and gentlemen. It's my great honor to be invited and to give speech on this international advanced training program of respiratory therapy for critical care. And first, let me share my slides. And today's my topic is invasive respiratory support for ARDS, evidence-based strategy. I'm Dr. Huang Xu from China-Japan Friendship Hospital. I'm a doctor of respiratory ICU. And let's begin our topic from a case. This is a 45 years old male patient who was a taxi driver. He came to the hospital with the main complaint of fever with cough for 6 days and dyspnea for 3 days. 6 days before admission, he suffered from fever, chills, dry cough, stuffy and runny nose. The symptoms were improved after self-administration of Cefardine. But 3 days later, he developed high fever and couldn't respond well to clindamycin treatment. And dyspnea soon after developed. On the day before admission, the blood routine showed a decreased white blood cell and the increased liver function, and also the significant increased kinase. The arterial blood gas showed that he had a type 1 respiratory failure. He was then transferred to our hospital, underwent non-invasive ventilation, but he couldn't respond well to the ventilation, and he had a very low saturation of oxygen, and he lost his consciousness. Then he was intubated. He was a heavy smoker. Now we could see the physical examination of the patient. He had a tachycardia and increased respiratory rate with 35 per minute. And he was agitated, obese, under trachea incubation, and with the lungs osculation. We could hear there were low both sound of both lower lungs, no rouse and no pleural friction sound. The recheck of the blood routine showed a deteriorate of the white blood cell and also the arterial blood gas. We can see from this results that the patient has suffered a very severe hypoxemia and also the increase of partial pressure of carbon dioxide. And the X-ray after 7 days of the onset, we could see that there were glass ground opacities and consolidations on both sides of the lungs. And the lesions were distributed mainly in basal basement and also the subpleural regions. The chest X-ray also showed the similar findings. We could see that there are significant consolidations on both sides on bilateral lungs, especially for the basal segments. So we can summarize the character of the patient. He had acute onset in winter. He had high fever, dry cough, progressive dyspnea, decreased white blood cell with the chest findings of bilateral subpleural GGO and consolidations at the base. And he couldn't respond to the Cefardine and clindamycin. And we thought it would be severe community-acquired pneumonia, mainly because of the viral pneumonia. We suspected the patient had the influenza, and we did the bronchoscopy first. The results showed type A influenza and also the secondary infection of MRSA. And we give antimicrobial agents immediately. So besides the diagnosis of severe community-acquired pneumonia, the patient also were in line with the diagnosis of ARDS. he had acute onset within 7 days of trigger. He had severe hypoxemia with PF ratio below 100. And he had a bilateral infiltration. And also the acute heart failure and fluid overload were excluded. So for such patients, what should we do? Especially what should we do on mechanical ventilation? First, let's look back to the pathophysiology of the ARDS patient. There are two kinds of changes in such patient. One is the injury of epithelium and the loss of surfactant, which means the decreased compliance of the both lungs and the baby lung. And the second is the injury of endothelium of the capillary, which caused the increased permeability of the capillary and the pulmonary edema. And so that's the two parts of the pathophysiology. And also the lesions of ARDS, especially for the typical ARDS, their lesions are not so heterogeneous. And we can see from this picture that the upper part of the ARDS patient had almost normal lungs. And if we give high pressure to such a region, maybe we could put excessive transpulmonary pressure on it. And the patient could suffer from a high risk of ventilator-induced injury. And so for the regions here, we should avoid a wall trauma or barotrauma. And for the middle part and the lower part of the lungs, we could see the lesions are totally different. And for this lungs, if we use mechanical ventilation, the patient may have the high risk of tidal recruitment, that is atelectasis trauma, and also the stress injury. And also the lower part of the lungs, maybe the high pressure couldn't open up the lung. So the first thing we should do for such patients is to avoid a wall trauma or barotrauma, and also the atelectasis trauma for such patient. So it is the first strategy, lung protective ventilation. And let's see what evidence told us about the lung protective ventilation. This is the guideline from 2017 ATS, ESSAM, and SCCM guideline. And this guideline strongly recommended the low tidal volume and the limitation of plateau pressure. But we could also see that this is a range of the volume recommendation. And so how should we precisely set up the tidal volume? And there's the first rule. The more severe the ARDS patient is, and the smaller the tidal volume we should set. And so, is there any other rules we have to obey? And does the tidal volume matter, or the plateau pressure or driving pressure matters? So we can see from the below studies that it is the driving pressure, but not the plateau pressure or the tidal volume that matters. And the mortality and the risk of barotrauma has closely relationship with the driving pressure. So we have to monitor driving pressure very closely. And for this patient, we set initially for the tidal volume of 5 milliliters per kilo. That was about 350 milliliters. And we also measured the respiratory mechanics for the patient. The plateau pressure was about 30, and the resistance was 12. The compliance was 25, and the driving pressure was about 16 centimeters of water, which is a little higher than the upper limit. And From the lung protective strategy, we know that maybe we have chance to protect the lung from ventilator-induced injury, but the low tidal volume couldn't open up the lung, and we have to find other measures to open up the lung and keep the lung open, and that is the PEEP. We all know that PEEP is a double-edged sword. It could benefit the patient from opening the lungs, and we should give higher PEEP for more severe ARDS patients. But the best way to precisely set up PEEP is not so clear. Until now, we are using PEEP FL2 table to set up PEEP. And also a higher PEEP could have detrimental effects for the patient, like alveolar overdistension and barotrauma, and worsening of the intrapulmonary shunt, dead space, and pulmonary vascular resistance. It could also decrease the cardiac output and unstable hemodynamic. So we should set up PEEP crucially. There are two tables for setup of PEEP: lower PEEP FiO2 table and higher PEEP table. Which one should we use depends on the PEEP recruitability trial. If the patient had the recruitability, we should use higher PEEP table, and on the contrary, we should use the lower PEEP table. So this person, we increased PEEP from 5 to 15, and we observed 3 parameters, that is oxygenation, the carbon dioxide, and also the compliance of the lungs. And we didn't see any improvement of these 3 parameters, so the patient was not recruitable. We used the lower PEEP table to set up PEEP. And we set up PEEP at 15 centimeters of water with the FiO2 of 1.0. And now we have set the tidal volume and PEEP, but the patient was still suffered from severe hypoxemia with PF ratio only 62 milliliters of mercury. And so what else should we do next? There are several choices for this patient. Should we use a higher PEEP, or should we use recruitment maneuver? Or if we should turn over the patient as prone position, should we deep sedate the patient, or even use the neuromuscular blockers, or even we should prepare ECMO for the patient? First, let's see, is there any space for this patient for a higher PEEP or recruitment maneuver? It's not the same as the recommendation to the tidal volume. There's conditional recommendation for the higher PEEP and recruitment maneuver in moderate to severe ARDS patients. And I think we should first look at this very famous clinical trial, ARDS trial, which compared the higher PEEP and recruitment maneuver to lower PEEP. This study has recruited more than 1,000 patients. Half was recruited into the low PEEP group and half in high PEEP, according to respiratory system compliance and RM group. I think maybe they for thinking of the investigators that the higher PEEP and RM may benefit of severe ARDS patient, but the results was so out of the mind. And we could see from the survival curve of the right side that the mortality rate on day 28 in high PEEP and RM group, the mortality was higher. And in control group, the mortality was lower. And besides, we could also see that the 6-month mortality, the ventilator-free days, and the pneumothorax or barotrauma, and also the vasopressors use and the hypotension, they are all favors the low PEEP group. So we have the question that why couldn't higher PEEP and RM benefit the patient? And just like the tidal volume, higher PEEP and RM had both sides of the coin. And it could reduce the driving pressure. At the same time, it may increase the overdistension and hemodynamic impairment. And we could also see the small differences between two groups. There are a small increment in driving pressure and relatively higher PEEP in control group and strict adherence to lower tidal volume. So maybe the strategy in control group is good enough to decrease the mortality of the ARDS patient. And for let's look back to our patient, if we should increase the PEEP or not. If we look at this lower PEEP table, we could see that if you use the FL2 at 1.0, and there's still some space for the PEEP increase. So we decided to take a try. We increased the PEEP from 15 to 18, but unfortunately, there's still no improvement of the oxygenation and also the carbon dioxide and compliance. So we didn't do RM for the patient. And to think a lot about this patient, we could see that from CT findings, the consolidations of both basal segments of the patient, that's the character of the patient, which means that the patient may not benefit from the higher PEEP and also the RM. And if we use higher PEEP or higher pressure to the patient, the gas will go to the upper part of the lungs, and the upper part may suffer from overdistension, and the lower part couldn't open up either. So we think there must be some other strategy or adjunctive for this patient, and maybe as the prone position. We all know that prone position could improve oxygenation from improved BQ ratio and the uniformity of gas blood distribution, and to reduce ventilator-induced lung injury and eventually reduce mortality. So we could see that the guidelines strongly recommended us to use prone position in severely EU ARDS patient. And for our patient, the lesion was gravity dependent, and the plateau pressure was higher than 30 centimeters of water. So we give prone position for the patient, and we could see the improvement of PF ratio from 113 to 136. And also there are some tips for this patient. We have to care about the tube fixation and the deep analgesia and sedation to decrease the patient ventilator desynchronization. And also we tried RM after prone position. We used 10 centimeters of watery PC and 30 PEEP. And we saw a higher oxygenation than simply prone position. And after 4 days of prone position, we could see the improvement from the X-ray, that the resolvement of the consolidation of the patient. And the oxygenation was improving gradually. So there's another question for the patient. Since the patient was severe ARDS patient and the PF ratio was only about 60, besides higher PEEP, low tidal volume, and prone position, what should we do about the sedation, and should we use neuromuscular blockers? This is the character of the patient. The patient's driving pressure is 16 to 18, And with a tidal volume of 350 and under analgesia and sedation, the respiratory rate was as high as 30 rates per minute. So should we use an NMB? And this time we have to go back to the physiology first again. And from these paragraphs, we could see the difference between spontaneous ventilation and the control ventilation. And the spontaneous ventilation, the gas from the patient, the gas inspired first goes into the lower part, that is dorsal part of the lungs, and the total lung volume could increase. On the contrary, for the control ventilation, we could see that the gas goes into the upper part of the lungs, and the total lungs volume decreased a lot. And we could see from the right circle that the lung volume decreased a lot. And also, if we keep spontaneous ventilation, the patient could wean from the ventilator faster. And it seems that to keep this spontaneous breathing is much better than the control ventilation. But we still could face some patients like this one. There are two severe ARDS patients I have met, and from the graphs below, we could see that the patient was suffering respiratory distress, and the tidal volume and the respiratory rate was very high. And such patient would have the higher transpulmonary pressure and high risk of barotrauma. So I think for such patients, we should use neuromuscular blockers. Neuromuscular blockers could also benefit the patient, especially for the severe ARDS patient. First, it could decrease the patient ventilator dysynchrony, and we could set tidal volume as what we want, and there's no need to care about the patient spontaneous breathing, and it can also decrease the inflammatory effect. So I think that's the theory of neuromuscular blockers. And now let's see the evidence from the clinical studies. There are two famous studies which comparing the neuromuscular blockers and also the placebos. And this is the first one, accuracy study. And the ARDS patient was divided into two groups. One is placebo group, and the other is cisatricurium group. And more than 300 patients, if their PF ratio is below 150 and with appropriate PEEP and low tidal volume, but with higher plateau pressure as high as 32 centimeters of water, and the patient would be recruited in this study. And we could see from the study that the patient who was given neuromuscular blockers had a higher survival rate than placebo group. And also we could see the other outcomes, which include 28 days death and ventilator-free days from day 1 to day 28, and the days without organ failure, days outside ICU from day 1 to day 90, and also the barotrauma and pneumothorax. We could also see that all of above results favors the neuromuscular group. And also we would pay attention to the complications of the neuromuscular blockers. And we could see from the green line parameters that the MRC score and the ICU acquired crisis there are no difference in two groups. So from this study, we could see that neuromuscular blockers could give benefit to the severe ARDS patients. And there are several guidelines which recommend us to use neuromuscular blockers in severe ARDS patients, like PF ratio below 150, that should be used continuously 48 hours. But in 2019, there's a big challenge from Rose study, which is almost the same study design to the accuracy study. And we could see that it's also a multi-center RCT, which compare the patient with neuromuscular blockers and deep sedation and light sedation patients. And we could see the opposite result, that the 90-day mortality in both groups are similar. And also the other endpoints, like day 28 in hospital death, or ventilator-free days, ICU-free days, or the other outcomes, we could see there's no difference. But we could see the ICU acquired weakness and cardiovascular events, there are higher rates in the intervention group. And why similar study design got the opposite results? If we look deep or profound into two studies, we could see the difference, different core from the similar appearance. And first, we could see that the PEEP set in both studies are different. In accuracy studies, the lowest PEEP was 5 centimeters of mercury. And in Rose study, it was 8. And in accuracy studies, the control group had deep sedation, but in Rose study, the control group was with light sedation. Which could explain that there are more cardiovascular events in intervention group. And we could see there are more PPV in accuracy study than in Rose study. And also there are a small group of patients whose PF ratio was beyond 150 before randomization. And Rose study has included patients more quickly. And there are more exclusive patients in Rose study who was using neuromuscular blockers before the inclusion of the study. So we could see that in Rose study, the control group had a much protective strategy for the patient, and which may dilute the benefit of the neuromuscular blockers. And also, we could see the evidence from the observational study. That is a famous study which designed in 2015. That's the Invasive study. The secondary analysis of Invasive study show that if the patient keep spontaneous breathing, the patient would have better ICU survival, shorter ICU length of stay, and longer ventilator-free days, especially for the patient with PF ratio lower than 150. So, as we have known all of this evidence, should we use neuromuscular blockers for our patient? And I think we have to use the neuromuscular blockers individually for the patient. We could see that the driving pressure of this patient was as high as 16 to 18 centimeters of water, and the respiratory rate was high. The patient's condition was severe, and he had high risk of barotrauma. He had respiratory distress, and deep breath maybe, and abnormal breathing style. And for such patient, we should use neuromuscular blockers. So we give rocuronium for this patient continuous for 48 hours and followed by intermittent use in prone position. Of course, we know that there are many detrimental effects of neuromuscular blockers. So we give close attention to the side effect of neuromuscular blockers, like the strength of the muscle and the ability of cough and the side effect to the cardiovascular system, and also any signs of nosocomial infection. And after 1 week of such protective strategy for the patient, including low tidal volume, appropriate PEEP, and prone position, and short duration of neuromuscular blockers, we could see the patient's condition were getting better and better. And the CT scan showed us a partly resolved consolidation of the lower part of the lungs. And after another 2 weeks, we could see an almost normal chest CT. And the patient got extubated and transferred to general ward and eventually recovered. So it's the summary of my experience into the case, and also my own recommendation for such patients. First, the lung protective strategy is still the cornerstone, include the lower tidal volume according to the driving pressure. And also we should use the appropriate PEEP for ARDS patient, although we should obey the rules that the more severe and higher the PEEP. But if we should use a much higher PEEP or RM for the patient, we should do the recruitability trial first. And if it is positive, maybe there's space for higher PEEP and recruitment maneuver. And for patient, especially the patient of gravity-dependent lesion, we should use prone position ventilation. A strong recommendation for the candidate. And the last, the neuromuscular blockers, we should use it for the high-risk patient. The patient who with severe ARDS and with respiratory distress, especially patient ventilator dysynchrony and large tidal volume and a higher respiratory rate, or the abnormal breathing style, is the high-risk patient for barotrauma, and we should use neuromuscular blockers for such patient. Of course, at the same time, we should pay more attention to the side effect of all of these above strategies. So thank you.